How do we recognize hypoglycemia? In other words, what are the presenting symptoms of a patient of hypoglycemia? They can be divided into three types of symptoms: autonomic symptoms, neuroglycopenic symptoms, and non-specific symptoms. What are the autonomic symptoms? The autonomic symptoms are due to excess of sympathoadrenal outflow, which can result in increased epinephrine and norepinephrine and acetylcholine. Increase in the acetylcholine produces sweating, hunger, and paresthesias. Increase in the norepinephrine and epinephrine produces palpitation, tremors, anxiety. These are the autonomic symptoms. Neuroglycopenic symptoms, that is brain experiencing lower blood glucose. Confusion, drowsiness, speech difficulty, anger, inability to concentrate, incoordination, irritability, visual disturbances, ataxia, and sometimes even convulsions. And of course, unconsciousness. Non-specific symptoms include nausea, headache, and tiredness. So, there are three groups of symptoms: the autonomic symptoms, the neuroglycopenic symptoms, and non-specific symptoms. Likewise, the signs of hypoglycemia also will be autonomic, neuroglycopenic, and others. What are the signs due to autonomic disturbance? Sweating, pallor, tachycardia, increase in the systolic blood pressure. In the case of shock, we do have sweating, we do have tachycardia, but the blood pressure will be low. Here there is tachycardia, there is diaphoresis, but the systolic blood pressure is increased. This immediately tells us that it is not a case of vasogenic shock, it is a case of hypoglycemia. Neuroglycopenic symptoms, focal neurological deficits, there could be twitchings of the face, there could be facial paralysis, monoparesis, or there could be sensory disturbances. Any types of focal neurological deficit can occur. Ataxia, and then seizures. Seizures are very important, particularly if the hypoglycemia is severe, something like less than 40 milligrams of blood sugar, then seizures are a possibility. Any patient who is convulsing, we should think of hypoglycemia if he is not a case of epilepsy. Others, signs of underlying causes may be there, or history of oral hypoglycemic agents being used or insulin being used by the patients will be the clues to find out that this is a case of hypoglycemia. To go a little further into the signs and presentations of morbidity due to severe hypoglycemia, as we have already seen, CNS manifestations like cognitive impairment, coma, transient ischemic attacks, convulsions, focal neurological deficits, and to some extent permanent brain damage. Cardiac, like cardiac arrhythmias, myocardial ischemia because of low availability of fuel to the heart. In ophthalmic, vitreous hemorrhages can occur due to hypoglycemia, and retinopathy will worsen. It is known that the swings in the blood sugar between hyper and hypo are the cause of worsening retinopathy. Others, like patient may end up in an accident, particularly road traffic accidents, they may injure themselves, or there may be hypothermia. Remember, severe hypoglycemia, if prolonged and untreated, can be very fatal. In order to confirm the diagnosis of hypoglycemia, we need these three things, which is called the Whipple's Triad or Whipple's criteria. First thing is the symptoms of hypoglycemia, the autonomic symptoms, the neuroglycopenic symptoms, and the other types of symptoms, and the presentation of a patient with a picture of hypoglycemia. Secondly, we must demonstrate that the blood sugar is low, something around less than 45 milligrams, by doing a blood test. Third thing is, these symptoms must immediately resolve and patient must become all right after the administration of glucose either orally or parenterally. If these three criteria are met, like symptoms of hypoglycemia, low blood sugar on blood testing and relief of the symptoms with glucose, then sure we are diagnosing the patient to have hypoglycemia. So this is called Whipple's Triad. So response to decreasing glucose levels, what happens in the body? The first and primary defense, of course, is a reduction in the output of insulin from the pancreas. This increases the rate of appearance of glucose and also reduces the rate of disappearance of glucose into the system. This is the primary or the first defense which occurs as soon as the blood sugar is around 80 to 85 milligrams per cent. The second defense, primary second defense, is of course increasing the secretion of glucagon from the alpha cells of pancreas. As soon as the blood sugar is around 65-70 milligrams, there will be glucagon production that increases the rate of appearance of glucose by glycogenolysis from the liver, and that is the primary second defense. Increase in the epinephrine, if the blood sugar is around 55 to 65 milligrams per cent, if this epinephrine increases the rate of appearance and decreases the clearance, so much so the blood sugar is maintained. This is a very critical third defense. If the glucagon is deficient or if the patient is not having glycogen in the liver, then of course epinephrine becomes critical in maintaining the blood sugar. Of course, the other hormones like adrenal cortisol and growth hormone are also stimulated around this blood glucose level. They also produce an increase in the rate of appearance and decrease in the rate of clearance. And remember that cortisol and growth hormone are not critical in the maintenance of glucose levels in the normal state in a hypoglycemic patient. Of course, food ingestion, when the blood glucose is around 50 to 55 milligrams per cent, there will be extraneous need or urge for taking more some food immediately, and that is exogenous source increases the glucose into the system, and around 50 milligrams, if there are no cognitive changes are there, food ingestion will be the ideal way of replenishing the hypoglycemia. The one organ that suffers most during hypoglycemia is the brain. So let's know some facts about our brain. Brain is the major glucose consumer. It consumes around 120 to 150 grams of glucose per day. So from the amount of food that we eat, around 1/4 of it or 1/3 of it is utilized by the brain. Glucose is virtually the sole fuel for the brain. It cannot utilize any other fluid like fatty acids or ketones or proteins or any other fluid, glycogen. It can utilize only glucose. Brain does not have enough fuel stores of glycogen. At the most, the glycogen that is there in the brain lasts for 4 to 5 minutes. It cannot metabolize fatty acids as fuel. It requires oxygen always to burn its glucose. Only aerobic glycolysis is possible. So brain, not only glucose, it requires oxygen. So glucose and oxygen are two vital ingredients for us to keep the brain going. Cannot live on anaerobic pathways. One of the most fastidious and voracious of all organs. It requires food. It requires readily available food, the glucose. Oxygen and glucose supply cannot be interrupted to the brain. So this is, and remember one more thing, brain for the glucose to be utilized it uses glucose transporter which does not require insulin. Insulin is no use or not required for the brain. If the glucose and oxygen is available, it's adequate.